Welcome to Raaonline. The most important prerequisite for any thoracic surgery is to isolate the lung. You have to isolate the operating lung from the non-operative lung. So, first thing is whether you are able to isolate the lung and what are the different options available to us to isolate the lung. And third one is what are the various problems you can face in the perioperative period by isolating the lung. What are the indications for one lung ventilation? In other words, what are the indications for lung isolation? Cardiac procedure. For example, you are doing a minimally invasive surgery where you are doing a thoracotomy. You have to isolate the lung. Your thoracic surgery, pneumonectomy or lobectomy, mediastinal procedures like posterior mediastinal mass or anterior mediastinal mass, you have to isolate that particular side of the lung. Your vascular pathology, descending aortic aneurysm or ascending thoracic aortic aneurysm, you have to isolate the lung. Esophageal and spine surgery, again you have to isolate the lung so that the surgeon can access that particular structure without any lung interfering with that pathology. In short, any procedures involving the thoracic cavity, you might have to isolate the lung. Another important indication for lung isolation is to prevent soiling by the contralateral lung in case of bronchopleural fistula, pulmonary hemorrhage and whole lung lavage. Third indication for lung isolation is differential pattern of ventilation in case of unilateral deep perfusion injury as it happens with lung transplantation or pulmonary thromboendarterectomy. It can even happen in unilateral lung trauma. What are the options available for us to isolate the lung? There are usually three common methods. The first and foremost is the double-lumen tube. By double-lumen tube, you mean you have a bronchial tube and you have a tracheal tube. So, you can isolate the lung. That is the most common way of isolating the lung. Next comes the bronchial blocker, where the blocker goes and obstructs the main stem blocker. So, you can isolate that particular lung from the remaining lung. The third one is the single lumen endotracheal tube, which goes into that particular bronchus where ventilation is required. Thereby, the lung goes into one particular lung and the other lung is isolated. These are the three common methods which are done for lung isolation. Now, let us look at the most common technique, which is the double-lumen tube. It is a bifurcated tube having endotracheal and endobronchial lumen. There is two lumen. One is tracheal lumen, another is bronchial lumen. It can isolate the right or the left lung. The first tube which was introduced for double lumen is Carlens tube way back in 1950. Carlens tube was a landmark in the development of thoracic anesthesia because it allowed a reliable lung isolation in majority of patients, and what you need is only a laryngoscopy and auscultation. With this, you can isolate the lung. And features of Carlens tube is it has a narrow lumen, so there is going to be high resistance to airflow. Next important structure is the carinal work. Okay, this carinal work made Carlens tube difficult to pass through the glottis. These are the two difficulties, narrow lumen and the carinal loop. And Robertshaw a decade later modified the Carlens tube. Here he did two things. He removed the carinal work, so passing to the glottis is prevented, and there is a larger lumen. Most of the disadvantages of Carlens tube was removed by Robertshaw. It had a bigger lumen, and there is separate right-sided and left-sided double-lumen tube in Robertshaw. Then the 1980s and 90s saw the disposable double-lumen tube, which is transparent. Here you have bronchial lumen, which is colored in blue, and the tracheal lumen, which is white or grey, you can say it. This is the bronchial pilot balloon and this is a tracheal pilot balloon. and here you can see the bronchial cuff in blue color and the tracheal cuff. So this disposable double-lumen tube is made up of polyvinyl chloride made on the design of Robertshaw double-lumen tube. There is radiographic marker near the endotracheal as well as the endobronchial cuff, which is very important. This radiographic marker surrounding the ventilation start of right upper lobe bronchus in case of right-sided double-lumen tube. The endobronchial tube are bright blue, low volume, low pressure cuff and allows easy visualization during fiberoptic bronchoscopy. Then slight modification came with Vivasight double-lumen tube. Here it has an integrated camera which can allow continuous visualization of its position inside the trachea. That is very important. So, you can continuously view the double-lumen tube. The camera is embedded at the end of endotracheal. Endotracheal, there is a camera. There is an integrated flushing system that allows in situ camera lens clearing. So, you can clear the lens regularly, at the same time you can view the tube position inside the trachea. You have a video connector, a flush port, tracheal cuff, and you can see the video camera with the LED source, bronchial cuff, and this is a flush port exit to create the screen, pilot balloon for the tracheal and the bronchial cuff, and you have the bronchial lumen and the tracheal lumen. And after laryngoscopy, the tube is inserted and the video connector port is being connected to the monitor, and here you can see the left mainstem bronchus with the bronchial cuff and the right mainstem bronchus. So, you can continuously view the tube position inside the bronchus and the trachea. The advantages, it gives continuous airway monitoring, whether the double-lumen tube is in proper position. It facilitates immediate correction of malposition at the level of tracheal carina. A good visualization happens. A defogging solution should be used prior to insertion. It enables more rapid placement when compared to conventional double-lumen tube. It eliminates the need of flexible fiberoptic bronchoscopy. The disadvantages, connecting the camera for prolonged period in vitro may lead to melting the portion of the tube near the light source. The heat generated might melt the tube. Next comes the ECOM double-lumen tube. Here you have multiple electrodes on the cuff, and this continuously measures the bioimpedance signal from the ascending aorta in close proximity to the trachea. With this bioimpedance signal, it calculates the cardiac output in conjunction with the arterial catheter. So, with this multiple electrodes on the cuff, you can calculate the cardiac output, and this helps in deriving the hemodynamic parameter, particularly in high risk thoracic surgical patient. You have the leads, you have the connector, and you have the cardiac output. Here you have 4 sensors which is located in the double-lumen tube. This sensor will measure the cardiac output, and you have a connector which will be connected to the monitor. After laryngoscopy, this double-lumen tube will be placed inside the trachea and it go into the respective bronchus. Here you can see the connector being connected to the monitor and the blood flow being sensed by the sensor, and it is reflected as a cardiac output in the monitor. This is how you can calculate the cardiac output using a double-lumen tube. This becomes very important when there is going to be hemodynamic instability during thoracic surgery. Next comes the Silbroncho double-lumen tube. Sil stands for silicone. The unique characteristics of this silicone is flexible wire reinforced endobronchial tip. It has a beveled bronchial orifice. The reduced bronchial cuff length that increases the margin of safety when compared to other designs of double-lumen tube. It is particularly useful for tube exchange from single to double-lumen tube in combination with video laryngoscopy and tube exchange catheter. So, you have the siliconized endobronchial tube. It is 100% silicone, designed to maximize patient comfort. There is a resistant cuff which is designed to resist puncture and tearing by teeth. The wire reinforced bronchial tube to prevent bronchial loom compression when patient is in lateral position and to reduce the instance of kinking and to assist X-ray verification. The narrow bronchial cuff help to reduce the chance of upper lobe obstruction, and a soft flexible tip facilitates endobronchial intubation and reduces the risk of trauma during intubation. This is Silbroncho double-lumen tube. Now coming to the size of double-lumen tube. This is size of double-lumen tube are given in French. We have size from 26 French to 41 French. Up to 32 French you can use a 2.4 millimeter fiber optic. Beyond that you can use 3.5 millimeter fiber optic tube. The what is very important is this size in French should be compared with the endotracheal tube internal diameter. 26 French corresponds to 6.5 millimeter endotracheal tube and 41 French corresponds to 10 millimeter endotracheal tube. It is very important to know the diameter of the bronchial lumen and the tracheal lumen, and you should have a comparison with the single lumen tube. For example, this is an 8 millimeter endotracheal tube and this is a 35 French double lumen tube, and you can see the external diameter is far bigger than the 8 millimeter endotracheal tube, and this is the 10 millimeter endotracheal tube, and here you can see the 41 French double lumen tube. The external diameter of 41 French double lumen tube is larger than the 10 millimeter single lumen endotracheal tube. Compared with single lumen tube, double lumen tube have a larger diameter, and what is very important is you should not advance against any significant resistance. That is very important. Now coming to size selection, properly sized left-sided double lumen tube should have a bronchial tip 1 to 2 millimeters smaller than the patient left bronchus diameter, which allows a space occupied by the deflate bronchial cuff. That is very important. Your chest X-ray and CT scan are valuable tools for selection of proper double lumen size. In addition, it gives an assessment of any abnormal airway anatomy. The images, the X-ray images as well as the CT images should be analyzed before the placement of the double lumen tube. In a study which was done by Hebel and Associate, what he did is, he assessed the size of the airway, trachea and bronchi with the CT images, and he compared the double lumen tube, and for each patient they came with particular size of double lumen tube to be placed inside the operating room. So, this was very successful. So, analyzing the image of the anatomy of the trachea and bronchi is very important for proper sizing of the double lumen tube. This is the normal anatomy. You can see the trachea right and the left bronchus. This is a normal tracheal bronchial anatomy. And here you can have an abnormal tracheal. Here you can see the tracheal deviation. Here you can see the left main bronchus is compressed by an enlarged aorta. So, this type of anatomy is very important. When you have an abnormal anatomy, you know it is going to be difficult to place the double lumen tube. Now, coming to normal and abnormal anatomy. Here you can see the normal anatomy, trachea and the left and the right mainstem bronchus. Now, you are introducing the tube, and the tube is going into the left mainstem bronchus and properly positioned. Now, imagine there is some abnormality on the left mainstem bronchus. Here you can see the left mainstem bronchus is cut, and this was caused by an aneurysm of the arch of aorta which was compressing the left mainstem bronchus. Now, if you introduce the double lumen tube, it may not pass in the left mainstem bronchus and it goes into the right side, although it is a left-sided tube. Now, coming to the selection of double lumen tube size based on the patient height, which is the most important variable for detecting the size of the double lumen tube. And it is based on sex. For females less than 160 centimeter, the appropriate size is 35 French double lumen tube. If the height is greater than 160 centimeter, a 37 French double lumen tube can be used. In case of male whose height is less than 170 centimeter, you can use a 39 French double lumen tube. And if the height is going to be greater than 170 centimeter, 41 French double lumen tube can be used. For females of short stature, that is less than 152 centimeter or 60 inch, you can consider 32 French. For males of short stature, that is less than 160 centimeter, you can consider 37 French. Now, coming to method of insertion, how will you insert the double lumen tube? There are two ways. One is blind technique, another one is you can visualize your double lumen tube. And you have various method of visualization using fiber optic or video laryngoscopy. You can have fiber optic or video laryngoscopy. Now coming to blind technique. Here the double lumen tube is passed with direct laryngoscopy. You pass the laryngoscopy and pass the double lumen tube, and most important thing is it is turned to 90 degrees counterclockwise for a left sided double lumen tube after the endobronchial passes beyond the vocal cord. The most important thing is it should pass the glottis without any resistance. These are all bigger size tube, so you should properly size it and pass without any resistance. The mean diameter of the cricoid ring is approximately same of the left main stem bronchus. The optimal depth of insertion for a left-sided double lumen tube is correlated with patient height in average size adult, and it is calculated from the teeth. Okay, you have a formula which is 12 plus patient height by 10 centimeter. For example, if the patient height is 160 centimeter, it is 12 plus 160 by 10, which gives 16. So, 12 plus 16, it is 28 centimeter from the teeth. That is very, very important. And in Asian population, many of whom are short stature, that is less than 150 centimeter. Here, the patient height is not a good predictor of depth of insertion. And inadvertently deep insertion of double lumen tube can lead to serious complication like rupture of the left main stem bronchus. Here the laryngoscope is passed, the glottis is seen and the double lumen is placed. Now it is passed beyond the vocal cord. The double lumen tube is passed via laryngoscopy beyond the vocal cord. Here you can see the two cuff, bronchial cuff and the tracheal cuff. As it passes beyond the vocal cord, you have to rotate 90 degrees counterclockwise, and here you can see the left bronchus, and this is the tracheal cuff and this is the bronchial cuff, and this is approximately at a distance of 27 to 29 centimeter from the level of. The most important thing is you cross beyond the vocal cord, rotate counterclockwise, go to the left side, and the distance is roughly 27 to 28 centimeter. So, DLT is passed with direct laryngoscopy beyond the vocal cord, then it is rotated 90 degrees to the left counterclockwise. Here you can see the rotation, then it is advanced to an appropriate length which is at 27 to 28 centimeter at the level of teeth. Now coming to direct vision, bronchoscopy guidance. The tip of endobronchial lumen is guided into correct bronchus using the flexible fiber optic bronchoscope. There is an higher success rate with bronchoscopy when compared to blind technique. There is no doubt about it. Blindly you are putting, and here you are having visualization. So, the success rate is going to be higher. But one disadvantage is it takes more time when fiber optic is used for placement of double lumen tube. However, it helps in safe and correct placement of the double lumen tube. Now coming to fiberoptic bronchoscopy, you place the double lumen tube. The double lumen tube is passed beyond the vocal cord. Here it is crossed beyond the vocal cord. Now a fiber optic is passed into the bronchial lumen. Here you can see the right and left main stem bronchus. This is a carina, this is a right bronchus and this is the left bronchus. Your endobronchial is passed into the left main stem bronchus. Now the double lumen tube is guided into the left main stem bronchus, and here you can see the right through the tracheal. Once the fiber optic is passed into the tracheal lumen, here you can see the right main stem bronchus and left bronchial cuff going into the left main stem bronchus. This is how you do a fiber optic bronchoscopy. Another important technique is video laryngoscopy. You can do a video laryngoscopy and localize the vocal cord and you can place the double lumen tube. It is an important technique in the management of patient with unexpected or an expected difficult airway. It improves the visualization of laryngeal structures and usually facilitate the insertion of single lumen tube. When compared to double lumen tube, it is usually used for single lumen tube, but there are studies which compare the CMAC video laryngoscope with McIntosh and Miller blade, and video laryngoscopic view were very similar to the view obtained with Miller blade while passing a double lumen tube. In contrast, the McIntosh blade had reported a higher difficult intubation with double lumen tube. They have studied comparing glide video laryngoscopy and McIntosh direct laryngoscopic, and they have shown that overall ease of successful intubation was higher with McIntosh when compared with glide scope, and also voice change was less common with McIntosh. This made a recommendation that glide scope is not recommended in patients who have normal airway while using double lumen tube. Another video laryngoscope, AirTac video laryngoscope, there was an improved exposure of supraglottis during insertion of double lumen tube in patients with normal airway. Video laryngoscope, when used for placing the double lumen tube, the most important thing is the experience of the operator in using the video laryngoscope and anatomy of the patient airway. Now coming to the positioning of double lumen tube, whether the double lumen tube is in proper position. Auscultation alone is unreliable for confirmation of proper placement of double lumen tube. Auscultation and bronchoscopy should both be used each time when the double lumen tube is placed and again when the patient is repositioned. Normally, when you ventilate with the double lumen tube is correctly positioned into the left main stem bronchus. Here you have not occluded any lumen, so you can hear the bed sound on the right side, and the right side hemithorax rises and fall. You can change the gas moisture disappears on inhalation and reappears on exhalation. Your left side air entry is heard, the left chest rises and fall, and the compliance is for both ventricles, so the compliance will be good. Now you are blocking the left endobronchial lumen. You are occluding the left sided bronchial lumen. The trachea is ventilating. Now you can hear the air entry on the right side as trachea is being ventilated. The right side thorax rises and fall, and you can see the gas moisture appearing and disappearing on the tracheal tube, and the left side there is no air entry and left side thorax does not move at all, and the compliance is for one lung ventilation. And another important thing, as the bronchial lumen is blocked, and you can see there is no moisture in the bronchial tube as it is clamped. Now coming to clamping of the tracheal lumen, you are blocking the right tracheal lumen. The trachea lumen is blocked. here the air entry to the trachea is prevented. Now, there is no sound on the right thorax. The right chest cavity doesn't move. There is no moisture in the tracheal tube. On the other hand, as the bronchial lobe is ventilated, there is left-sided air entry. The left hemithorax rises and falls, and the moistures can be seen on the bronchial tube, and there is going to be expected compliance for one lung ventilation through the bronchial lumen.